say motor neurorehabilitation, some of you may be familiar with this term, but generally it refers to rehabilitation or recovery from a motor movement or a neurological brain-related disorder. Okay? So it turns out that there's a lot that fits within that umbrella. I myself was a target of rehabilitation. I'm going to start by talking about that. Who's going to advance this? Well, I think someone will come up on stage and help me advance the slides. So I'm just, oh, okay, there we go. All right. So that is a picture of me wearing one of my favorite soccer jerseys from 2009, and I am rehabilitating my knee. Okay. The incident that led to this was, at the time in 2009, I was an avid amateur soccer player. Avid, I was very interested. Amateur, I was not very good, but nonetheless, I did play soccer quite a bit. Okay. Those of you who played soccer will know of a move, awesome, thank you, called a Cruyff turn. Okay. Coined by a famous Dutch soccer player. This is a move whereby you plant one leg, you shield the ball, and you twist around that leg. Okay? The purpose of doing this move is to simultaneously shield the ball from the opponent while also changing direction very quickly. Okay? Again, I was an amateur, right? So I've seen lots of famous soccer players do this, but when I tried to do it, something went pop. Okay? So we have good audience members here. Can anyone tell me what went pop when I tried to twist my knee? ACL, it's famous, yeah. Anterior cruciate ligament. In your knee, you have anterior, posterior cruciate ligament. Among other things, when you try to twist about that knee, these help stabilize. But if you twist too much, then you may pop something. Okay, so my left knee that you can see in the image there went pop. I went to see a physical therapist. I did the recovery surgery. And ultimately, what happens after you get the surgery is you go home and you have to maintain a bunch of different tasks, okay? So I went home. I hope my physical therapist is not watching because I did something like 70% of what I was supposed to do, okay? Why did I only do 70%? Well, I still had to work, so there were times where I was pressed for time and I just needed to get to work, or I needed to cook, or had other things sort of pressing on my schedule. Other times I forgot exactly what I was supposed to do, so I would get a sheet of paper or I would write down, take some notes, but I would get home and I couldn't quite remember, okay? So there's sort of these two competing issues here. One issue is me going home not remembering what I needed to do or not being sufficiently motivated to do what I needed to do. But also when I went back in and saw my clinician, she would say, hey, what did you do? And I would say, I did what you told me to do, right? But I wouldn't necessarily remember everything, right? So there's also this issue of my physical therapist trying to make decisions when she doesn't have the complete picture of what I was doing when I wasn't being supervised. So that's really what I want to talk about today, this idea of how we can, one, help the clinician to better monitor what's happening to people when they're not in the clinical setting, and two, how can we influence those individuals? How can we change their behavior in those clinical settings? And that's really what I'm referring to here with motor neurorehabilitation. Okay, so it wasn't just me. Lots of people have had the ACL injury. In fact, in the US right now, there's about 100,000 people per year who one way or another end up damaging the ACL. About half of those individuals go on to get the surgery to repair that ACL. One interesting question that some of our clinical partners have posed is, do we know what people are doing immediately after the surgery? And I'll talk a little bit later about why that might be important for long-term outcomes. But there are lots of other populations, as you start to think about this, who might benefit from this kind of an in-home care. Those of you who know, we are living in the stroke belt here in East Tennessee. There's a very high incidence of stroke within this region, okay? For those of you unfamiliar with stroke, stroke essentially means some type of cell death in the brain. Oftentimes that cell death occurs in one hemisphere, and you can see that the opposite side of that individual has some partial paralysis. So a large number of these individuals have upper extremity problems, gait problems, facial problems. Over 800,000 people a year in the US are having stroke, and that number is increasing, okay? So for these individuals, we know that increased practice with that limb when they go home is critical. If they don't get increased practice, they lose some of the motor function there. They may lose some of the neurological substrate that's required to control that limb. Quality of life changes. There are all of these other additional comorbidities or other medical problems that can result from simply not getting increased practice with that limb. So if we can monitor how people are using that limb and encourage them to use that limb, again, in the home setting, that can make drastic difference in people's lives. And beyond just monitoring, there are a large number of other groups for whom home practice would be important. So for individuals who receive cochlear implants, many children are born with some partial hearing loss. They may receive a cochlear implant, and what becomes important is practicing verbalizing those words, practicing hearing those words, and doing it correctly with a therapist. Sometimes this can be done over the internet, but oftentimes the therapist may have limited time. People may be remote from a location where they can get treatment. So
thinking about these populations, are there ways we could provide something in the home setting for these individuals that could help them with some of that practice? And of course, I'm talking about these because these are all things that we're doing to some extent in our lab. So at a high level, the approach that we're taking and how I'm trying to think about some of these technologies as ways of assisting the existing, or I should say supplementing the existing healthcare system, is illustrated by this image, okay? This image, if you're an engineer, you might recognize as a block diagram for a control system. If you're not an engineer, let me just quickly explain what that is. We all utilize control systems every day. To think about a simple example, you're on the 40 freeway, you want to go 70, well, some of us don't want to go the full speed limit, but I want to go 70 miles per hour at least on the freeway. So what do? I apply an actuation to the system, I move my foot. What does that do? That forces the car to go some speed, okay? Now the car is going some speed, how do I know what speed it's going? I need to use some kind of a feedback loop. So I look at a speedometer. It tells me I'm going 60, okay? I know 70 is the target, 70 minus 60, I can say is 10. I'm an engineer, I should be able to do that math at least. And I see now that there's this error of 10, so what do? I adjust my foot again. So this is, the reason we call it a control loop is you're constantly looping until you minimize that error to get to a point where you want to be, okay? In our approach, we're looking at the human as the system that we're trying to control, and specifically the symptoms of the disease that that human is displaying. So that human has some disease, let's say stroke or Parkinson's disease. We're using wearable sensors to measure some component of that disease. Now, it's a sensor, it's a wearable sensor. In other words, this is something you place on the body. This is something like a watch or some external non-invasive device. So it's not telling us nearly everything we need to know. It's only giving us one signal. But nonetheless, we're taking this signal, we try to make some meaning of that signal, and then when we talk about minimizing the error, we want to reduce the effect of that symptom. So we now want to apply some type of input to the system, and in this case, what we use is a combination of virtual reality and social robotics, okay? So, in my remaining time, I have plenty of remaining time, well, not plenty, I have enough remaining time. I'm really going to focus on these two topics, wearable sensors and social robotics, and how they relate to this broader idea of looking at motor neurorehabilitation in the home setting. Now, when it comes to wearable sensors, can anyone name a common commercially available wearable sensor? Fitbit. What is Fitbit doing? Step counting, yeah, but you're wearing it on your wrist, right? But what it's doing is when you take that, when you go through that gait cycle, it's looking at how many times you're swinging that arm, and it's using that to estimate, okay, for most people, they swing their arm once per gait cycle, therefore I can reconstruct the number of steps this individual has taken, okay? That's one of a large number of sensors that are available. Can anyone think of something that they may not be thinking of as a sensor, but most, if not all of us, have it sitting in our pocket right now? Yeah. That's not an audience plant, I promise. Okay, cell phone, right? So what sensor does your cell phone have that might be used to monitor your motion? Gyroscope Accelerometer. So for those of you who are not familiar, accelerometer is a device that measures acceleration in 3 axes, linear axes. Gyroscope measures rotation about axes, okay? When you flip your phone and it changes the face, that's because the accelerometer recognizes gravity is shifted, and I need to shift this image, okay? So on your phone, these devices are used not necessarily to monitor you, but to make sure that the phone has some desired functionality. But we can use those same types of sensor devices to monitor how people are behaving in these types of settings. So the accelerometer, these pictured in this plot are data from an accelerometer. In particular, if you look at the plot on the left, what you will see are data from a stroke patient. Okay, so this is work that was done during my postdoctoral work. We asked an individual with stroke. This individual had hemiparesis, so one side was a little more limited than the other side in terms of stability, in terms of motor control. We placed 3-axis wearable sensors on each wrist. So again, you have 3 axes of motion, so when this person is moving around, we can measure that in 3 axes, and therefore you have 3 different colors, red, green, and blue, that hopefully you can see there on the plot. If you look on the left side, this was in the lab setting. I asked the individual to perform a task, I have to look to remind myself, with the right hand and then with the left hand, okay? And if you look, you see nothing is happening initially on the plot as you move from left to right, and then something happens with the right hand, okay? The person did the gesture. Then nothing's happening, then something happens with the left hand, okay? In the lab setting, if we want to think about how this person is performing or what these sensor data mean, we take a clinician, the clinician can look at these data and say, this person has difficulty with pronation and supination, or this person has difficulty with motor control. And then we can look at how the data relate to that. And we can say, this is what good data look like, and this is what bad data look like. However, if you send someone home with the sensors and ask them to do whatever they're going to do, it's a very different story. The plot on the right are data from the same individual wearing the same sensors at home, okay? So whenever I show this, I like to say to people, if you can look at that plot on the right and tell me what that individual is doing, then come work for me. I'll pay you lots of money right now, okay? Because it's a very hard problem to extract from these raw data some type of meaningfulness. So this is where working closely with a clinical partner becomes critical. Again, we have to be able to say from a clinical perspective what's happening to an individual and compare that to the data that we get from these sensors. Another application domain, again, goes back to repair of the ACL. So I mentioned my own situation, which was more focused on monitoring the extent to which I could practice once I went home. But equally important is long-term development of additional problems. And some number of people who receive ACL repair or ACL reconstruction, they end up developing osteoarthritis. They end up with higher incidence of the potential to re-injure themselves. Why is that? Well, this comes down to something that we think is what we call a motor compensation, okay? We think early after the injury, or I'm sorry, early after the surgical intervention, that these individuals change their behavior. So what does that mean? If you have a stiff or painful knee, or you have pain in your knee, well, if you don't have pain in your knee, when you're going through that gait cycle, you have to be able to flex at the hip, flex at the knee, right? That is what's necessary to ensure that you don't trip when you move through that gait cycle. Now, if you have pain in your knee, or your knee is stiff, you're less likely to be able to bend that, right? So our brains are smart, our brains are trying to solve a problem, so the brain says, oh, I know what to do, just rotate at the hip here. Do this out of sagittal plane rotation at the hip, and that will allow you to get through the gait cycle. You don't have to bend your knee. Everybody wins, right? Everybody does not win, because what happens is when you're doing this compensation, you're now doing something that is not an expected activity. You're now loading your body in a way that it was not meant to be loaded, okay? So one thing that our clinical partners asked us, we have clinical partners at USC who said, can we look at what people are doing? Can I put a sensor on a person, send them home, and you come back and tell me they walked this amount of time, they were sitting this amount of time, and then go and target those walking periods and look for what were they doing from a biomechanical perspective. So that's one thing that we've initiated, where essentially we started by putting a bunch of sensors on an individual. Here you see an individual wearing a downward-facing camera for confidentiality reasons. We don't want to film all you guys because you wouldn't like that. But that downward-facing camera allows us to see the gait activities this individual is doing, so we can compare them to the data that we're getting for the sensors that you can see this individual is wearing on the thighs, the shanks, and on the hip. So what we've done so far is we've classified different types of activities. What we're continuing to work on is looking at those gait dynamics, gait biomechanics as the individuals walk and perform these different tasks. So this is something we're very excited about. We've looked at a large number of populations. I alluded to Parkinson's disease. We're doing some work with some folks with PD here in the Cole Neuroscience Center at University of Tennessee. We're very interested, again, in looking at upper and lower extremity deficits and stroke. And some of you at this point may be thinking, okay, cool, fine, you've convinced me. Well, some of you may not be convinced, but some of you are at least thinking, okay, you've convinced me that monitoring is important, but what about changing behavior? How do we go about doing that? And that's where the social robotics comes in. Okay, so what's social robotics? All of us know about robots. All of us have seen some social robots. Even in old days, Rosie is vacuuming, and of course in pop culture we have lots of robots doing lots of things. But how can we look at these robots as a tool that, again, in the home setting can provide either motivation or provide some type of an intervention that extends the therapist into the home setting? So this is an image from some of the work during my postdoc. This is a social robot. His name is Bandit. You can see he's very muscular. This was developed in the lab of Maja Mataric at the University of Southern California, but the purpose of this social robot was to work with various populations. The reason I'm saying social robot is the robot does not physically interact with the individual. There are plenty of robots that do physically guide people through different tasks, but if you imagine something like stroke, where people need to eventually be getting back to washing dishes and dressing themselves and doing other activities of daily living, having a robot that physically guides you through that task is not necessarily what you need. You need something that perhaps can provide you motivation or information on how to change your own behavior and able to do that better. So in this study, this individual is performing a reaching game, reaching to different buttons, because the robot's saying, reach to this button. The individual tries to reach as quickly as possible. The robot's giving feedback about time, because it turns out that humans, if you tell them anything about time, want to go faster the next time, okay? So this is a way that you can sometimes motivate people intrinsically to do something when they may not have otherwise had the motivation. Now, in this setting, the robot is basically acting as the guide for the game, okay? This individual is playing the game, but nonetheless, he's doing a functional activity that forces him to do ipsilateral reaches with the limb, contralateral reaches with the limb, both of which are important for recovery in these individuals. So again, this picture is coming from a clinical setting, but this is a system that now has been piloted in the home setting, and we, in fact, are now using a variation on the same principle here at Tennessee, looking at the cochlear implant problem. Now again, as I mentioned, for children with cochlear implants, oftentimes they need lots of increased practice verbalizing, hearing how a word is verbalizing, and associating that with an image. So this picture represents a social robot that we're using in the lab now, in collaboration with folks here in speech and audiology at UT. And specifically, this robot is meant to follow the same type of procedure that the clinician would follow in the clinical setting or even over the internet. Now, some of you may be saying, okay, fine, do it over the internet. What's the purpose of the robot? Part of the premise behind social robots is that physical embodiment and physical presence helps people to attend more closely to the robot. There's evidence in different populations that if you're using an embodied robot and compare that to a laptop or compare that to pen and paper, you're more likely to persist with the task, you're more likely to focus on the task. Again, this is not for all populations, but certainly for some populations. The children working with these robots are going to be 2, 3, 4 years old. So you see the robot's holding the mic, he's going to put the mic up. We help the kid lean in, wants to interact with the robot. But functionally, what did we do? We took an off-the-shelf robot, which is basically designed as a toy. We 3D printed the head. So I think most of us are familiar with 3D printing. These kind of look 3D printed, but they probably would. But for those of you not familiar, 3D printing is a process whereby you build a three-dimensional object in software, you send it to a printer, and it constructs it out of plastic or metal or some other material. But we 3D printed a head, and we took the phone, and one of the individuals in the program is actually sitting in the room today, so I'm glad he made it. But we took the cell phone and programmed that cell phone to provide specific responses to the individual. In other words, the robot speaks to the child, it puts up an image, the child verbalizes, the phone can use a voice recognition software that's essentially built into the phone, monitors that information, then provides a contingent feedback, okay? So again, the point here is that it's contingent, it relies directly on what the child is doing, and it's based on the underlying theory behind what the speech therapist would be doing normally with the child. So to wrap, again, these are just a couple of examples, and certainly if you're more interested, please email me. I'm always interested in having more discussions with other researchers, with patients, with doctors, these types of things. But really, again, getting back to this idea of re-examining some of the technologies we're currently using in order to ensure that they can be useful in the healthcare domain. Now, I'm going to finish with a question, and this is a question that used to be posed to us lots of times whenever we would go present this work, and I'm hoping that I've done my job correctly, and it's not a question that's on your brain. But in the old days, whenever we would present this, people would say, oh, awesome, robots, yeah, cool, very cool. Okay, when will these technologies be able to replace clinicians and doctors? And I can tell you with 100% certainty that they will never replace the expertise of our clinicians and docs. These are meant to be tools that supplement or augment what these individuals are already doing. In other words, tools to help the clinician see what's happening in the home, tools to help the clinician affect what's happening in the home. I didn't have time to mention them all today, but I have plenty of clinical partners. All of these problems are based on working directly with the clinician to determine what is the underlying medical problem we want to solve and which technology is best meant to adapt to this. So anyone who's watching this now, here or online, if you have thoughts on that, or if you're saying, oh, I can teach this guy a thing or two, that's fine. I'm welcome to hear anything, but I'm always looking for more information and insight on how we can make these technologies better capable of helping people with their daily lives. Thank you.